Okay. Welcome everybody, everybody who's here in the room as well as on the Zoom call. My name is Patrick Hayden. I'm the president of the Wellesley chapter of Rotary, and I'm an 18-year resident of Wellesley. We're happy to be co-sponsoring the event this weekend with the Wellesley Public Library. Kara Rothman is co-producing this event with us, and we appreciate her support for that. This is the first of many presentations we're going to have here at the library over the course of this year. We're going to do a few more in the winter and then again in the spring. The speakers have not been announced yet. We're still working on that, but stay tuned for details on that. Rotary Club of Wellesley runs many events here in Wellesley. We have a team of about 23 people who run events like this, as well as Taste of Wellesley and Dinner on Us. Dinner on Us is actually a program that we are going to be kicking off next week. This is something where participants have an opportunity to win $3,000 in gift cards. The grand prize is winning $3,000 in gift cards to 20 different restaurants, which would make a heck of a stocking stuffer. So 30 different restaurants, sorry. So anybody who wins can wind up with a heck of a lot of gift cards for stocking stuffers and things like that. And there's going to be $5,000 in total prizes for that, even more than that actually. So look out for that. We're always looking for volunteers to join the team. Taste of Wellesley is going to be a great event this year. We're going to be holding it at the Wellesley Country Club this year for the first time. So we're looking forward to that change. It's going to be very different, and it's going to be a very different look. There's going to be a lot of preparations, and we'll need a lot of volunteers to help such an event like that in a new location. Dinner on Us that we're kicking off now is also going to keep us busy. We have a fun holiday party every year. We manage to find a good band every year for that party. Yes, I'm looking at Shira. She and I played at that party last year. We're going to do it again this year. Okay, I'm going to introduce Dr. Shira Doron now. Dr. Doron is an infectious diseases physician. She serves as the hospital epidemiologist at Tufts Medical Center and the chief infection control officer for the Tufts Medicine Health System, where she was the subject matter expert for the COVID response. She's recently elected to a member to the Wellesley Board of Health. Dr. Doron is a consultant to the Massachusetts Department of Public Health and sits on its hospital-acquired infections technical advisory group. And during the pandemic, she served on Governor Charlie Baker's medical advisory board and worked closely with the Commissioner of Education on school reopening. She speaks nationally on topics ranging from prudent antibiotic use to prevention of hospital-acquired infections and has authored over 80 research papers. Since the pandemic began, she has published more than 20 lay press op-eds and participated in over 2,000 media interviews. And I can tell you that she also rocks animal prints like leopard prints and zebra stripes better than anybody you'll know. So it's my pleasure to introduce very good friend, Dr. Shira Doron.
Well, thank you, Patrick, for that lovely introduction. So I'm going to talk about this concept of using crisis for innovation. In the context of how I led the hospital infection control response to a global pandemic at Tufts Medical Center and at the Tufts Medicine Health System. So let me set the scene for you. It's January 2020. There's an outbreak of unexplained pneumonia in China, and we're hearing that hospitals there are filling up. And we're hearing that people are dying. And it might be coming for us. Now, this is what I've trained for. This is what I've prepared for. I've been doing drills for 20 years to prepare for this moment, but I didn't ever want to arrive at this moment. So we sprung into action. We started educating. We were in constant communication with the staff in the hospital. We started doing drills. We did PPE, or personal protective equipment, donning and doffing training. Now, of course, healthcare workers know how to put on and take off their PPE, but we wanted to make sure that we knew and they knew that they could do it correctly and safely. We repeated fit testing on everyone for N95s. I think everybody knows the word N95 now, but probably didn't in January 2020. And you may not know that we don't wear those N95s unless they are fitted to our face, and we've tested them to make sure. And this is a picture of N95 fit testing. You put a hood over the healthcare worker's head, you spray something caustic into that hood that makes them cough or taste something, and you make them speak while they're wearing the N95, and you make sure that they don't sense or taste anything, and that's how you know that it fits. And we provided tons and tons and tons of reassurance. You can do this. Tufts Medical Center, where I work, is a 415-bed hospital, so not very big and not very small. We have adult and pediatric patients, although you may have heard that we recently closed the pediatric side of our hospital. We are in downtown Boston, Chinatown, which is obviously relevant as this outbreak was originating in China. We're an academic teaching hospital with students and residents and fellows and co-op students from Northeastern and nursing students and tech students. We're a tertiary care referral center, so most of our patients come from other hospitals rather than through our emergency room, and we're part of the larger Tufts Medicine network that includes Lowell General Hospital and Melrose Wakefield Hospital. So I'm going to show you a lot of pictures tonight, many of them snapped by some of our nursing colleagues really during the height of the activity there. And so, you'll see here on the left, donning and doffing training. We started with our leaders. We made sure that everybody knew how to don and doff, put on and take off their N95, their eye protection, their gowns, and their gloves. And you can see on the right, a nurse getting ready to go into a room with one of our first COVID patients there, eye protection, N95. Now, she was wearing head coverings. One of the things that we had to deal with is people wanted to cover more parts of their body, shoe covers, head covers, but actually the more PPE you have, the more you risk contaminating yourself when you're doffing, which is the riskiest time. And so we had to combat some of that sentiment. And so it's February now, and we've learned that containment within China has failed, that the virus is spreading across the world, that Italy is getting absolutely slammed, that New York City is overwhelmed, and college students are returning from break from all over the world. And in Boston, a lot of college students were returning from China. It's been a bad flu season, so there are a lot of sick people in our emergency room, in our clinics, and they all have COVID symptoms. We sensed that we're next, and of course we were, and so we begin emptying the hospital. We haven't even seen our first actual COVID patient, but we stopped doing surgery, which is really the only way we make any money, and we empty the beds and wait. And that's when the fear became really absolutely oppressive. So the World Health Organization declares a public health emergency of international concern. And now we start evaluating patients for that novel coronavirus. It wasn't called COVID yet, it was nCoV. And we realize how constrained testing is. The CDC and the Department of Public Health in Massachusetts tell us we have to follow strict testing criteria. So we have a patient in the emergency room from Wuhan, China, with a cough, but no fever, no test allowed. We have a patient from Wuhan, China with fever, but no cough, no test allowed. Now, of course, today we sit here and we know that you can have COVID with a cough and no fever, and you can have COVID with a fever and no cough. We had a patient from China, but not Wuhan, with fever and a cough, who had shared a taxi with a driver from Wuhan, who was sick throughout the entire taxi ride, and it was a long taxi ride. No test. And all of those patients get sent right out the door to rejoin society. But all of those patients are initially evaluated with personal protective equipment, and we're already running low, and we haven't even seen an actual positive COVID patient yet. So we begin to prepare for a real onslaught, and we're running out of supplies. The supply chain is disrupted, hoarding is occurring, hoarding at drugstores, when people go to drugstores and buy up all the masks from the shelves, hoarding by other hospitals who got to the supplier first and bought all the N95s. We realized how much we rely on China for our supplies. That's where they're made, and in China, they're on lockdown, and they're not interested in making PPE for the United States. And we realized that even though we had been planning for a pandemic and we had warehouses full of reserves of PPE, it wasn't even close to enough. And now it's March 2020, and the patients start arriving. So the problem was 3 S's: space, stuff, and staff. Space, really ICU beds. We had a certain number of intensive care beds, and that wasn't even close to enough for the number of critically ill patients that were flowing through our doors. Stuff, I talked about the PPE. We also didn't have enough ventilators for all those critically ill patients. We didn't have enough test kits, or tests, period, to test the people that we wanted to rule out or in for COVID. And then staff. You didn't have enough nurses, physicians, and respiratory therapists for the number of people that needed critical care. So we leaned in on some basic survival principles. First of all, what do you already know? What can you take from the knowledge and the experience that you have that you can apply to this never-before experienced type of situation? Keep an open mind. We said over and over again, there is no idea that is ridiculous. Anything you thought was right might be wrong, and anything you thought was wrong might be right. Think about the fact that we never allowed anyone to reuse a mask, ever. We thought that was dangerous. But there was no way we were getting away with getting through this situation without reusing our masks. And we had to stay at the cutting edge of knowledge. Do not miss anything new. Read, read, read. I had to know what the latest research was on how the virus was transmitted, how to control it, how to treat it, or our staff and our patients would suffer. And we had to be fast. My CEO said to our group, at this point, we've activated hospital incident command structure. We started our day in the command center at 7 a.m. We left around 11 p.m. He said, if something needs to be done, make sure it's done in 24 hours, every single time. So I needed to read, but the problem was that we were now, by May, in an infodemic with over 23,000 papers published on COVID-19 by May 13th, and a doubling time, which is a phrase we use to describe the virus, but could also be used to describe the literature on COVID-19, of 20 days, and that doubling time was shortening. And so if you can imagine, I'm working in the hospital from 7 a.m. to about midnight. I'm also getting up at 5 in the morning to read everything that's been published overnight. And so this is a curve showing the number of COVID positive patients in the hospital in our system, with Tufts Medical Center is in the darker orange, Lowell General is in the medium orange, Melrose Wakefield in the blue, and the overall for our system is the one at the top, obviously. We'd never seen volumes like this, and nearly all of these were critically ill. And we never would have guessed that we would be able to do it, but we did it, and we did it through innovation. So we innovated in space. No idea was ridiculous. We used unlicensed areas of the hospital that the Department of Public Health would have never allowed us to put patients in before. We used the post-anesthesia care unit as intensive care unit. We used non-ICU units as intensive care units. We used a pediatric intensive care unit as an adult intensive care unit. And some hospitals even had patients in dental chairs in their dental areas. We rapidly shifted to telehealth so that we could free up space in our ambulatory clinic areas. We canceled that non-essential surgery, and we did it early to free up space because people who have surgery need a room afterwards, and we couldn't afford those rooms. We put patients in the same room, sometimes 2 patients in a single room. And we made a lot of facilities modifications to do that. So if you're going to put critically ill patients in a regular hospital floor, you have to cut holes in the doors and put windows in them so you can see them. We had to change the pressure gradients because we're a transplant center, and many of our rooms have air pressure that flows outward so that the patients who are immunocompromised don't have germs coming in under the door. But if the air is flowing outward and all those patients have COVID, then you're blowing COVID into the hallway. And we used a lot of portable HEPA filters. It was very noisy. So this is a picture from one of our regular floors, our regular medical floors, on a day that it was being changed from a regular medical floor to an intensive care unit. This is the medical and nursing leadership team standing in the middle, informing their staff that this floor was going to shift to being an ICU. Here's another picture about space, which is that we started setting up tents outside to prepare for whatever we needed to use the outside space for. We did not put patients out there, but we did put our testing center line out there, and we used those tents to provide some shelter to people who waited, often on lines that stretched half a mile long. So staff. We innovated to stretch our staff because we had not enough, not the right kind, and we needed to keep them healthy and strong so they could take care of patients and each other. But fear was probably the biggest issue. Everybody, without question, came to work every day, but that doesn't mean that they weren't terrified. And our protocols changed every single day. We learned something new about COVID every single day. We sent emails out every single day, and it was way too much information for people to be able to process. But our number one priority was staff safety. And what I often said was, I compared it to being on an airplane where the flight attendant will say, place the oxygen mask on yourself first before helping small children or others who may need your assistance. The number one priority is staff safety, because you can't take care of patients if you're not alive and well. You're my top priority, and patient safety is a close second. And so I leaned in on the basics. So this is a diagram called the hierarchy of controls from the National Institute for Occupational Safety and Health, and it's been around for 1,000,000 years. And interestingly, you'll see that the lowest item on the hierarchy is PPE, personal protective equipment. We focus so much on PPE because we had so little of it, but it is the least important element of control when you're trying to mitigate a hazard. And so the number one top tier strategy to mitigate a hazard is to eliminate it, physically remove that hazard. Next is substitute it, replace the hazard, then engineering controls, so isolate people from the hazard, and then administrative controls, change the way people work. And only the last would be personal protective equipment to protect the worker. And so these are some of the ways that we fit our strategy into that old school hierarchy of controls. We limited visitors and non-essential services. So we kept people out of the hospital as really morally injurious as that was, because, obviously, there's nothing worse than telling people they can't have visitors and telling people they can't visit their loved ones when they're in the hospital. That immediate pivot to telehealth that I talked about kept more people out of the hospital. Anybody who did not need to be in the hospital was working from home. We used a lot of plexiglass. We used a lot of floor markers to tell people where to stand 6 feet apart. We had never done virtual meetings and training before. Everything was in person prior to COVID, but we started to do that. We put tables outside so people could eat, so people could safely take their masks off and eat outside. And of course, we implemented universal masking, as did every hospital around the country. And so this is some pictures of our empty ambulatory clinics that really weren't seeing patients during this time, but we were preparing them for an eventual reopening with plexiglass and floor markers. This is the entrance to one of our floors turned into intensive care units with a sign that said stop to make sure that people didn't walk onto the unit not realizing that there are patients with COVID-19 and persons under investigation. And the nurses on that unit changed that stop sign to "Don't Stop Me Now," and decided to add some letters from school children that we had received in large quantities throughout that first surge. And I came up with my own hierarchy of mitigation measures because I realized that every day I was making these decisions and they fell into a couple of themes and they had their own order of importance. And so here's Shira's hierarchy of mitigation. It starts with regulatory compliance. If it's required by the Massachusetts Department of Public Health, it's non-negotiable and we do it. Second is staff safety, which is one and the same with workforce preservation and patient safety. Our primary goal is staff safety and patient safety, and anything that will contribute to that, we do it. But then there were other things that came into day-to-day decision-making, and I would argue they came into that decision-making too much. Optics. Does this thing look like it's mitigating the virus? Does this thing make people feel like they're safer? Temperature checks would be one of those things that was discussed. Proven not to be useful in COVID-19, but something that a lot of people wanted to do. Staff and patient comfort, a little bit different from optics. Things that staff and patients might be asking for, but might not actually contribute to safety. And then the last one was also a topic of daily conversation, alignment with outside entities. So our staff would say, but at the hospital across town, they do it this way. And that's the one I really had to try hard to avoid making decisions based on. So we continued to innovate with our staff, and we restructured how we provide patient care. A trained intensive care unit nurse who would normally have 1 or 2 patients in an ICU took 4 or 5. But that nurse was supported by non-ICU nurses who did tasks for the ICU nurse that were within their scope of training. So the ICU nurse might manage the vent or the pump, the ventilator or the IV pump with the drips on it, whereas the non-ICU nurse supporting that nurse might do things like vital signs and blood draws. We had surgeons, anesthesiologists, even psychiatrists staffing medical intensive care units. We had pediatricians taking care of adults. And to stretch our infectious disease expert resources, we took our non-infectious disease trainees and had them work under infectious disease attending physicians, and our infectious disease trainees and had them work under non-infectious disease attending physicians to really stretch that expertise. And then we started a program called ID Ambassadors. So we took our non-infectious disease respected attending physicians and we trained them in very specific tasks. So for example, we took an ophthalmologist and we trained him in who gets a COVID test indications. And he was assigned to support the emergency room on test indications. And every day he received updates from my team on what are the test indications today, because those things were changing every day. And so here's one of our most esteemed ID ambassadors. So you can see there in the blue sweater, that's Bill Mackey. He had been the chair of surgery at Tufts Medical Center for decades. He had recently stepped down. He was incredibly revered in our hospital. Every morning, he would get an update from infectious disease on the epidemiology of the pandemic. He would go to every floor, and they would flock to him like he was the Pied Piper. And he would tell the story of where we were. Support was the most important thing that we did for staff. So we created an intranet page, and my team had to become webmasters because the changes were so fast that we couldn't rely on anybody else to do it. And so you can see one of our COVID web pages for staff there on the right, where staff could find whatever the up-to-the-minute recommendations were on a variety of things. What's our PPE plan? What's our treatment plan? And then one of the, I think, the best things we did was we created something called the PPE support team. We had all these doctors and nurses and techs that either worked in outpatient areas or in the operating room that they were coming to us every day and saying, I don't know what to do. I have no job right now. Where can you put me? What can I do? And so we created this PPE support team. It started small, and it ended up with 70 members that sat with an infection prevention expert for 1 hour every morning, learned what the latest updates were, and then fanned out across the hospital at every unit, every shift, nights and weekends, and quite literally held the hands of the nurses that were doing the hands-on care of COVID patients, making sure they were putting on and taking off their PPE properly and answering any questions. We staffed a 24-hour command center. We assigned a nurse liaison to follow the infection prevention team around so that all of the communications we were doing were worded in such a way that nurses could best understand them. And we leaned in on the key principle of breaking down the hierarchy. There was no one that couldn't come to me. There was no one that couldn't go to the CEO. There was no one that couldn't ask anyone else a question or tell somebody what they were feeling. This is a picture of the command center on the left. Notice how pale we are and the bags under our eyes, but this is where we spent really, 16, 18 hours a day for months, and where we came together to make decisions. We look calm there. There were times when we weren't so calm. There were times when we yelled, and there were times when we cried. And then on the right, that's a picture of a PPE support person. They even had decided to make name badges that said PPE support team, helping an ICU nurse to put on her PPE safely. So I talked about stuff and our supply shortages, and we really innovated with our stuff. So when we were short on ventilators, we got ventilators from a veterinary hospital. We used non-invasive ventilators, the kind that people use for CPAP, as ventilators. When we were short on surgical masks, we started reusing our masks. We even ripped up surgical drapes and tied them around our faces like bandanas. We had volunteers sewing us masks. We didn't have to use those in the hospital in the end, but we did use those to go home and go to the grocery store because we certainly didn't have time to sew our own masks. For eye protection, we ran out of goggles right away, but luckily that was one of the easiest things to print on a 3D printer, and so we relied on our local colleges to use their 3D print shops to make us our eye protection. For our N95s, that is a really hard one to try to make by hand. So we use something called a powered air purifying respirator, and I'm going to show you what that looks like. And we reused the hoods so that we could use fewer N95s. We even had people using snorkel masks. Generally, to minimize PPE because of the shortage, we minimized room entry. And we did that, and you can see in the picture, by using extra long IV tubing so that the IV pumps that are normally right at the patient's bedside were actually outside the room and the door closed. Because we were spending less time in the room, we used binoculars to see the monitor. We used baby monitors to talk to the patients, and tablets so the patients could communicate. We ran out of hand sanitizer, so we got ethanol-based products from distilleries. We ran out of nasopharyngeal swabs ran out. We really never had any from the beginning, and so that's a picture of one of our 3D printed nasal swabs. We ran out of viral transport media for the COVID tests, so we made our own out of the raw ingredients. And we were always running out of disinfectant wipes, and so we were constantly reprioritizing who needed them the most and what kind to use. That's a close-up of a IV pole with long tubing so that it's outside of the room, and a nurse looking through binoculars at the patient. There, here on the left, you see our 3D printed eye protection, so big face shields. Luckily, that's a relatively simple piece of equipment. And then on the right, you see a nursing staff from one of our ICUs holding signs saying thank you for donations that we received of binoculars and baby monitors and apparently bagels. So these are the PAPRs, the powered air purifying respirators. And so on the left, those are the generators. And so those are plugged in and recharging there, and that goes around your waist. And then you see the hose there, that connects to the hoods on the right. And those hoods are supposed to be single use, but we had people write their names on them, save them, and reuse them over and over again, because at least it was your own germs. It creates positive pressure airflow so that viruses, pathogens can't come up into your mouth and nose because the air is flowing outward. This is one of our hand hygiene dispensers after we had to switch to stinky ethanol-based hand sanitizer that some people thought smelled like tequila, but other people thought smelled like jet fuel. And then we started a program called the Apollo 13 program. And the idea was that anybody who worked in the hospital could submit ideas for solutions to difficult problems, with no idea being too outrageous, and each submission would be vetted by the appropriate expert. And we had many difficult problems. And so here's one called the Splash Bivvy. So this was a team of anesthesiologists that came up with this invention that's essentially a hula hoop and clear plastic draping, and there is a hose that is attached to suction, and they're operating on a patient, and in those early days you didn't know how much virus was in the abdomen and how much was potentially coming out if you cut into the abdomen during a surgery. And so they had plastic around the incisions in the patient's abdomen, and they were suctioning the air right out of that space and into a filter. This is something we call the ventilated headboard. I actually found the specs for this in a remote part of the CDC's website as a strategy for building a field hospital during an outbreak of airborne respiratory disease. And so this was predominantly used in the post-anesthesia care unit, where you have many people in relatively close proximity with no walls. And everybody's after surgery is sort of coughing and spluttering, and you can't put a mask on them because they're sleeping. And so we used this type of device attached to a HEPA filter to essentially suck all the air that is swirling around somebody's face into a filter. And then some cowboys on white horses started to ride into town. We'd been feeling very alone, and the cavalry started to come. And the first one was Battelle. So this was a company from Ohio. They do a variety of things, but they arrived in Massachusetts, and they set up these containers in Somerville. And in those containers, they did this. They decontaminated our N95 masks with vaporized hydrogen peroxide, and we wore them over and over and over again. This little guy is called the Envo mask, and when I first saw the Envo mask, I took it straight to my CEO's office and I said, I need to show you something. I love it. I love it so much I think I want to marry it. It's a wipeable N95. You can wear it over and over again forever. It's got a filter in the front, but it's flat. And the company that makes it is in New Hampshire. And they promise me they can make as many filters as we need forever. And he said, buy it. And I said, how many? And he said, all of them. And I said, don't you want to know how much they cost? And he said, no. They were $75. And the Envos came. And here's the first nurse that got to wear an Envo. And that really helped. It really helped. Between Battelle and Envo, that really got us through the first wave. But there were more waves. And so these are Tufts Medicine COVID positive patients, a little bit a different way to count them, so the numbers are a little bit different there. But, we had 3 big waves, and they were all hard. But the impact on employees was quite different than the impact on patients. And so here you can see the first wave all the way at the left, and then the Delta wave is the second one. And you see where vaccination begins on December 16th. That was the day I got mine. And the second dose on January 6th. That was the day I got my second one. And the boosters become available there in the fall of 2021. And then you see what happens to our workforce in the Omicron wave. Decimated. Well, so we learned a lot of lessons about people. We learned that together we can do anything, things we never thought we could do. We learned that dealing with uncertainty is really hard, that fear is paralyzing, and I learned that the key to dealing with fear is to both acknowledge it and respect it, and that sometimes what's needed, what people need, is not a solution, but validation. I'm scared. You can't fix that for me, but I just need you to hear it. I learned that people, though, even when they're terrified, are really brave. And I also learned never to underestimate the power of a thank you, and free food doesn't hurt either. So I'm going to end here with a few pictures. This is a ceremony that we did in honor of the first 100 patients that died of COVID in our hospital. And so each one of those flower arrangements represents a patient who died in our care. This is our healthcare workers outside kneeling in honor of George Floyd's murder. I learned lessons in leadership. I learned that innovation can be really fast, especially if you keep it simple. I learned that dogma was my enemy, because sometimes I dug in on what I believed, and then it turned out that what I believed wasn't right. And I also learned that it was okay not to be unflappable during an unprecedented crisis, as long as I kept showing up. And I learned, for me, the most important thing was to always, always be honest and transparent. We are running out of N95s. I would like you to use fewer N95s. It's not because I don't care about you, it's because I do care about you, and I want you to have them when it really counts. Honesty, transparency. I really love these pictures. So this was towards the end of the first wave, back when healthcare workers were still heroes, before we were largely forgotten, and they announced that there would be a parade in the street in our honor, and that the first responders were going to be driving down the street with their sirens and their lights, and that everyone should, come outside or go to the windows and watch. And so this is our healthcare workers, exhausted, but waiting for the parade. And the sun is setting, and the first responders arrive. Thank you.
We're going to take some questions for about 15 minutes or so. We've got another 15 minutes until we get to 7:30. So we can take some questions from Luke. If you have any questions online from the Zoom call that you could read out, that would be great. In the meantime, if there's any questions for Shira, please fire away.
Yes.
Did you get COVID?
I did not get COVID until summer 2022.
How bad?
It's never fun. You know, I was in bed for about a week. Yeah,
Wow.
yeah. But I was, as it's cliche, but of course I was thankful to have had all my shots by then. So, yeah.
So in the beginning of your presentation, there was a slide from, WHO and no test, no test, no test. So now, what is their stance now? If they were to be faced with this again, would they still have that same?
Yeah, I mean that.
Can you repeat the question?
Oh,
Repeat the question?
Oh, sure, no problem. So Donna was asking about, how there were so many restrictions on testing, and, has the WHO, have other health authorities changed their stance on testing? Testing has been one of the most controversial aspects of the pandemic. Of course, there are many controversial aspects. In that situation, the problem was supply. And we, here in the United States, the CDC made a misstep very early on that delayed our access to testing, and really crippled our ability to detect the virus within our midst, more so than in other countries. And so those criteria for testing, which were so strict, were really just a function of the Department of Public Health needing to really control the number of tests that were coming to them and in turn to the CDC. Once tests became commercial and labs like Quest were up and running with testing, then we could test everybody, but in those early days, you might see a 7-day turnaround time. We had people that we told had to be on isolation to wait for the test result, and sometimes after a week, we told them that they never even had it. So, the innovations in testing, I mean, we talk about it, today like it's old hat. We really needed to ramp up quickly with rapid turnaround tests and ultimately home tests, which were further delayed in this country because, there was a fear that if people did tests at home, the government would lose the ability to track the virus. And they did, but it was worth it to get tests to people in the home. Yes.
Do you think the COVID-19 pandemic is continuing today?
Do I think we are in a pandemic?
Yes.
Yeah, I mean, I think it is totally semantics, right? It's however you define pandemic, and there is no one definition of a pandemic. So some people define it as something that changes the way you work, live, and play. Probably 99% of people are working, living, and playing pretty normally right now. So in that sense, we're not in the pandemic. Are we out of the woods? No. I mean, you saw that Omicron event and what it did to our workforce. After there had been vaccines, after there had been lots of infection-induced immunity, we could have another variant that evades immunity to the point where we could see another giant wave like that. Will it take us back to square one? No, it won't take us back to March of 2020 because now we know how to make tests and we know how to make vaccines. But, I would say COVID is heading towards endemicity, towards being endemic like the other respiratory viruses, but it's still more subject to big shifts, big ups and big downs because of its novelty. Yes.
Have you seen changes in the procedures and protocols from the government, like stocking, PPE, and all that? Is it different now than it was?
Yeah, so sorry about that. So the question is whether there are different protocols from the government in terms of stockpiling. I don't feel confident that we are funding or resourcing our public health infrastructure to be sure that we won't have many of the same problems the next time around. Memory is short, and the question of funding for public health has become very partisan. And, you would think that we would have learned our lesson, but I'm not sure that we have. Yes. What do I do now?
What are you doing now?
Oh, with COVID, like in the hospital?
No, I mean, what is your job now?
What's my job? Okay, so I had a job before COVID. So thankfully, I do more of my day-to-day work now, whereas I was pretty much all COVID all the time for probably a good year and a half. So what is the job of a hospital epidemiologist? I'm also at the health system level, something called a chief infection control officer. So my job is to prevent the transmission of disease within a healthcare system. So that's patient to patient, patient to staff, staff to patient, staff to staff, visitors in the mix, viruses, bacteria, fungus. It's to prevent the emergence of infection. So a surgical site infection, a device-related infection, like if somebody has a urinary catheter, there's a high risk of a urinary tract infection. So it's to put into place and implement all of the policies, procedures, and protocols that help to prevent those things.
Do you wear a mask when you go to the supermarket now?
The question is, do I wear a mask when I go to the supermarket? And the answer is no. And it's not because I don't think masks work. I think they do. But I am not trying to outrun the virus. I think you're the one who asked me if I've had COVID. I had COVID. It was not fun. But I don't think that I can outrun it the next time by wearing a mask in the supermarket. When we were doing a lot of contact tracing in Massachusetts, the overwhelming majority of COVID acquisitions happened in your own home. And so, maybe you can delay it a little bit, but we're all going to get COVID again and again throughout our lifetime.
Thank you.
Hello. Sorry, can I ask some questions from the Zoom?
Sure.
All right. So I have JC Opuda. Sorry if I said the name wrong, but they asked, have hospitals made any changes in their facilities' ventilation systems following the pandemic?
Yeah, that's a great question, and I've heard that asked before, and I think that people don't realize that we already had kind of the best ventilation you could ever have in a hospital. So there really isn't any need to make changes to ventilation in a hospital like there is an imperative to make changes to ventilation in other settings. Our rooms have many, many air exchanges and excellent filtration, and so it's really the safest place you can be.
All right, thank you. Next, I have a question from a woman named Judy Stone. She is also an infectious disease physician, and she says, it's a little bit of a long one, but she says, I was taught, first do no harm, yet many Boston hospitals have dropped masking, and patients complain that HCWs refuse to mask even when they are asked to. How do you suggest protecting vulnerable, immunocompromised patients when they suggest masking is unnecessary in healthcare settings?
Yeah, this is something that I think about all the time. As we were approaching kind of the end of the public health emergency, which I think was a political date, but it did coincide with a shift into a state of more thinking of COVID as one of many respiratory viruses, and we had to ask ourselves, are we going to be wearing masks in healthcare forever? Because if it wasn't going to be now, then there isn't going to be a better time for COVID, so it's essentially forever. And I had a lot of conversations with a lot of healthcare workers and a lot of patients about whether people were willing to do this forever. And the answer from most people was no. From patients, I want to see the face of my caretaker, my doctor, my nurse. When I want to receive good news and bad news, I want to see that person's expression. And from healthcare workers who said this is not the kind of connection that I want to have with patients. And there were many other considerations that have gone into this, but I would expect that what we'll see is a return to universal masks or masking in certain settings at least as the respiratory viruses pick up again this winter, and that we'll be continuing to think about this question very, very carefully over the next several years probably.
Okay, I'm going to ask one more, and then if anybody else in the room wants to ask, I'll give them space. But next one is from somebody named Michael Olison. Sorry if I said that wrong. He is an epidemiologist who also led the infection prevention of a large teaching hospital and have been on the facility of the APIC. Given that you were talking about staff safety, why is the HICPAC not pushing for mandatory respiratory protection in healthcare settings? There's evidence that we're going to be losing about half of our healthcare workers due to burnout, sickness, and death in around 5 years.
Yeah, so the HICPAC is a group of consultants to the CDC made up of hospital epidemiologists like myself, but I am not on that committee. And they have been looking to completely overhaul hospital infection control policy or guidance from the CDC. The last time the CDC released infection control guidance was in 2007, so it's high time. And one of the things that they're looking to do, one of the controversies during COVID that you may have heard of was this question of, is it airborne or is it not airborne? And it's really a false controversy because everyone knows COVID travels on air. The problem is that hospitals had this dichotomous distinction between droplet transmission and airborne transmission as if they were two completely different things when in fact they're on a continuum. And so the HICPAC committee is looking to get rid of that dichotomy, which is false, and they are creating a new category called air. And that will encompass infections that we typically used droplet precautions for and infections that we typically used airborne precautions for. But they actually have not yet gotten to the level of creating the grid by pathogen that says this thing requires an N95, this thing requires a mask. And there is a big misconception and headlines in the media that suggest that they're going to be recommending, regular surgical masks for COVID, which is not where they are. They are still just at the point of setting out those different categories, and the actual precautions that you take for specific organisms or viruses is a later stage that hasn't happened yet. Tina.
Dr. Doron, regulatory environment, you had that at the top of your hierarchy. Can you talk about the challenges of sort of the day-to-day, how things changed, and how difficult it may have been to be compliant? And if you were able to actually be compliant in that ever-changing sort of new rules being created daily, I'm sure.
Yeah, so the question is about the regulatory environment, the health authorities essentially creating new rules on a regular basis, and how hard was it to be compliant? Very hard, because, sometimes health authorities make rules that are in the best interest of the people, of course, but they don't know what it's like to be working on the ground. So, for example, during Omicron, a rule that said hospital workers who get COVID no longer have to be out for 10 days, they can be out for 5 days and come back earlier if they have a negative home test. Well, no one could find a home test. No one was testing negative before 10 days anyway after the fifth day. And so that wasn't helping us get our staff back to work anyway. And as you could see, we would have hundreds out each day. And so that was something we simply could not follow and still take care of patients. There were other rules like you have to have an electronic method for screening people for symptoms every day. We were stretched to our very limits and didn't always have the resources to put in place the protocols that the state was asking us to do as fast as the state wanted us to do them. The good news is that there was not a lot of unannounced visits from the state chastising us for the things we weren't doing, because they did also understand that we were doing the very best we could do with the resources that we had.
We have time for one more question.
I can give you one if you'd like.
Sure.
All right. Also, I'd like to say sorry to people on Zoom. We do have a time limit, so I can't get to all of them, and a lot of these are quite long, so thank you for understanding. Let me see. Jocelyn asks, honest questions, why are there any medical professionals anywhere starting to minimize COVID when the threat of being disabled by COVID with long COVID and the risks for so many other serious issues such as heart attacks, strokes, cognitive issues, diabetes are so high? I'm genuinely trying to understand how repeated infections, when every infection carries those risks, is sustainable for our species.
Yeah, so I mean, I think, I don't think that medical professionals who see COVID day in and day out, like myself, would ever minimize it. I mean, we had refrigerated trucks in the alley for the bodies. That is not fake news. That is real. But there are also headlines that are designed to create fear, to garner clicks, that are amplifying some of the research or some of the findings in a way that is actually making things seem worse than they are. Because we are not in March 2020. Things are orders of magnitude better. And if you look at some of the headlines, you would think that all of America is walking around with long COVID or organ damage. And that isn't the case. Some of those studies are deeply flawed. The rate of long COVID has gone down dramatically over the last 3 years. And some of the studies that suggest organ damage are looking at very specific populations of patients who have been in the hospital with severe COVID. So with the patients that I see in real life are really handling COVID very, very well with relatively minor symptoms. I never see COVID pneumonia anymore. And yes, sometimes there's a long tail on the end of that infection with fatigue that can last for a couple of months. But by and large, the vast majority of people who get COVID today are recovering completely and doing perfectly well. Thank you.
I just want to thank Dr. Doron again for coming out and making time for this. And I'd like to thank everybody for joining us on Zoom and taking an hour out of your evening. And thanks to everybody in the room for coming out. And stay in touch with Rotary. We've got a new Facebook page. Our old one got deleted, so if everybody, when they see our Facebook page, can like it all over again, we'd appreciate it. And we'll see you for the next event. Thank you very much.